My name is Paul Culpin. I'm Homa's colleague, both in the NHS and private world. So we both work at the Royal London Hospital, which is one of the big teaching hospitals. We are both hip, knee and trauma surgeons. So the Royal London's quite famous for its delivery of trauma care, which means that our NHS practice is quite heavily focused on probably the more complex end of the spectrum when it comes to orthopaedics, and we enjoy running a tertiary referral service from the Royal London. My scope of practice is really to do everything in hips and knees, and when we're dealing in our private practice, there is some relevant differences. It allows us the ability to practice electively what is often a bit more challenging than very challenging through the NHS setup. So it allows us to be more accessible and have our accessibility to diagnostics and operating in a very timely manner. And all of this is rather surreal because our worlds have been turned upside down with COVID, and NHS and private world have suddenly just really ground to a halt. And so this talk is going to was initially about what can wait and what cannot wait in COVID, but we're now feeling, I guess, at least in the private sector, that we have some hope ahead, and that some of these restrictions are being lifted. We're getting our resources back under control for us to be able to offer a service which I hope will get towards what we could offer before the COVID crisis has really overtaken all of our lives. So just before I go into that, I'm just going to mention a little bit about the group that we're in. So we're in a group called LIPS, which some of you may have heard of, but LIPS stands for London International Patient Services. It's a group of teaching hospital consultants that was initially focusing on the musculoskeletal consultants, but we've been expanding such that we're, I would think, probably the most rapidly growing group in London. It's a unique in the sense that all of our consultants are working at London's top teaching hospitals. So we're therefore all working both in private and in the public sector, which we hold as an important value and indeed I think a marker for quality. So we have a very strong presence at the London Clinic, which is where I'm doing this webinar from today. But actually, our group can be found throughout London, and it's not exclusive to any specific private facility or indeed any NHS facility. So it's given us the ability to recruit whom we think to be the very best people in their specialties. And so everybody that's come in has come through personal recommendation or indeed people that we've worked with, and we were able to vouch for their quality. And we know them to be good communicators and ticking all the boxes that you'd be looking for from your consultations, particularly in the private sector. I'll come back to that towards the end. So what I wanted to talk about was try to put knees as the topic for this evening, and put it into the context of COVID. So the lockdown happened in March, and just really overnight our access to elective care ground to an absolute halt. And so actually preceding that was slowing down rapidly, but the limited access affected the NHS and the private sectors in synergy, and it's meant that for the past 4 months or 5 months even, the patients have had really limited access to being able to get medical opinions. We've done our best to find innovative ways to connect to our patients, and Homa's session is I think taking value experience from the last few months, and it's definitely going to be something that will be with us going forward. But there is undoubtedly a big difference between seeing a patient remotely, and there comes a time when some patients need to be seen face to face, I think. the great limitation has not just been in the inability to access clinicians, but also the inability to access diagnostics. So therefore has been patients who for many months have not had what would be routinely investigated and in many cases resolved very quickly. They've been living with these symptoms for very many months. There is some hope in the COVID. COVID is at least in the London area rapidly declined to right now being very, very small numbers. And this has led to the launch of elective services in July, but because the NHS contract has remained with the private sector, there's still been fairly limited access. The breaking news in the last week or so was that the contract with the private sector will end in September. And so we should, at least in the private sector, be launching more rapidly into services as we previously had. The NHS is gradually gearing up also, but what we're dealing with is such a massive backlog and the issues for patients that have had essentially no treatment and no diagnostics for very many months. Patients have become very anxious. The messages have been confused, and it's been a rapidly evolving picture. What guidelines do we have to follow for how we are right now? These guidelines are changing fairly rapidly also. The latest NICE publication was from approximately 2 weeks ago, so the end of July, and this is focusing on how we're relaunching elective services, and obviously the priority is for us to do this in the safest possible way. However, the reality is that patients are just so worried about coming to hospital, and the numbers that we've seen, even with the launch of services, it has been, in a sense, I think, quite surprisingly small. The current recommendations are that for patients that are coming in for hospital care, that they have a 2-week period of isolation. However, the latest NICE recommendations are actually a bit more open than that, and this hasn't yet been adopted by all hospitals, but I hope that this will be rapidly changing. So the 14-day isolation should be applying for the higher risk patient, but actually the low risk patient, which is the vast majority of our patients, should be adequate for proceeding with care if they've been social distancing and hand hygiene for 14 days prior to their admission. And in addition to that, screening is done for COVID 3 days before their admission. The patient is warned that if there is any positive test, or if they're unwell or they need to self-isolate, then of course that intervention will be delayed. There has been a change in this dialogue. It's been, it's moved into an area where a more flexible approach is stated to be where we should be aiming our care and having this conversation of balancing risks, because I think we're all aware that that we've been overrun by the philosophy of limiting the risk to the patient in regard to COVID, but of course there's been other elements of their health that have suffered as a result of this. And this is, I think, a really important balance that we have to strike, and that affects the musculoskeletal and orthopaedic world also. There is an emphasis on identifying those at high risk, and there's a new consent that we take for all patients, but it's particularly relevant for the high risk groups whom you'll all be aware of. And the concern is that there is evidence that in the high-risk patient, around the time of surgery, if they do contract COVID, they're more likely to become severely ill. And this has to be discussed with the patient as an additional element to the consent process. So moving on to knees. Now, this is a talk that I used to give in the pre-COVID time. The city sportsman used to make up a very large part of my practice. The city doesn't really exist anymore with regards to people working in it, and people's activity level has changed so dramatically. So it has definitely altered how we're practicing. Sports injuries, team sports, they've ground to a halt. We missed the ski season, so that would normally be a busy time for knee surgeons, and would be at this point dealing with all of the ACL injuries. However, knee injuries are, of course, still happening, and we will be picking them up, I think, in the forthcoming months of patients that will be managing injuries in their home setting and the sequelae of that. Interestingly, just last week I had a patient come in, and probably a more common source of significant knee problem is just a simple slip at home. And the normal scenario is they have a painful swollen knee, difficulty in weight bearing, and they realise something's not right. And the access to services for them at that point is to go and get an X-ray, and very commonly that X-ray will return a normal result. And that patient is then passed on to follow-up services through perhaps a fracture clinic. The diagnoses we're thinking about in such patients is basically threefold. A normal X-ray, of course, does not exclude a significant injury, and seeing the patient subsequently and actually having a very low threshold for organising further diagnostics is really the priority. And an MRI scan is the investigation of choice for this. I wanted just to pick up on one specific sign, and Homa had Daniel demonstrating it really quite nicely. It's just so important that this is not missed and not treated as just somebody with some knee pain, have some physiotherapy, give this time and let's see if it gets better. A locked knee. The name itself is somewhat misleading. It implies that it's a knee that doesn't move, but that's just not the case, and it can be much more subtle than you may think. Here's a video of a patient that I did, I think it was last year. Get to lift your leg up in the air, and straighten it out. Straighten out your knee as far as you're comfortable to do it. So start to feel tension. So put it down now and see how straight you can get it. So you'll see rehearse like that. So you're about 20 degrees maybe. So this is quite an obvious limit to his extension, and as Homa implied, it's actually not always as clear as this. But you'll note with he has a bucket handle tear to his meniscus, but actually his knee is not massively swollen, and his inhibition at that point. Why is he limited to this much? It's pain that's inhibiting him. I took him to theatre after an MRI scan to confirm the diagnosis, and so when you see the knee comes out much straighter, but it's still not straight, and this is how it often looks. So it's very important to examine the other side and see what's normal for that patient. 5 or 10 degrees of not full extension is what a locked knee often presents as, and an urgent MRI scan is the next priority. And the sign that we're looking for is what we refer to as a double PCL sign, and that's it just there. You see, this is his posterior cruciate ligament, and it looks as though it has a neighbour following the same trajectory. This is his meniscus, which is flipped into the notch, and it's the meniscal tissue that sits in this zone that prevents his knee coming out straight, and that represents an urgent problem that, as an orthopaedic surgeon, we want to be addressing as early as possible. So just a little bit about the meniscus. The menisci are two structures, medial and lateral menisci. They're critically important. They cover, this is the medial meniscus, here's the lateral meniscus. You see they're discoid in shape, but they are actually quite differently shaped. And the cartilage on the medial side is much more exposed than on the lateral side. The role is as shock absorbers, the protectors of the underlying chondral surfaces. And they distribute the forces across a larger area and therefore help to preserve the cartilage surfaces. The lateral meniscus covering even more and offloading the cartilage surfaces on the lateral side more than the medial side. And that's probably why we see medial arthritis more commonly than we do lateral arthritis. What happens when we remove it? Well, contact stresses go through the roof. They skyrocket, and as a result of that, the patient is more prone to get wear and tear change. These are pressure mapping studies, which show some pretty pictures that show that after a meniscectomy, there's much more pressure generated in specific points. When a meniscus is intact, that is dissipated through a much larger area. And this is why the meniscus is such an important structure. And if we can preserve it, really we would like to do that. A meniscal tear comes in many shapes and forms. The one that we've been talking about for the locked knee is typically a bucket handle tear. Now, it's often much, much bigger than is seen here, but various shapes of meniscal tears can be seen. And a meniscal tear in a young person nearly always comes with a history of trauma. But as we get older, the meniscus, the shock absorber, just gradually changes in structure. And it doesn't take a lot of trauma. It doesn't take any great story for a meniscal tear to occur. Meniscus is a really important structure, but once it starts to crack up and become displaced, instead of protecting the cartilage surface, it can start to gouge it out and damage it. And this is why a persistent knee pain, locking, swelling, or a sense of instability to the knee are the mechanical symptoms that we want to take from the history. And these are symptoms that we would like to be treating the patients early with so we can limit the damage and, if possible, repair the meniscus. So a meniscal repair is actually quite successful. Most menisci are not repairable. If it's a degenerative meniscus, then it's not repairable. But in a young person, the success rates are really quite high. The problem is that very commonly these patients are just presenting too late. I'm going to touch just briefly on ligament injuries. I think it is very difficult for a ligament injury really to be assessed accurately remotely. A ligament injury is something that's so much better to get your hands on and assess because these are stress tests, but the history is also so important. I don't have time to go through all of the ligament injuries. Homa's touched on some parts of it, but this is a demonstration of an anterior draw test where a top tip for this is for you to sit on the patient's foot so it's stabilized. Use your hand to actually push up into the hamstrings to relax their hamstrings, and then use your weight just to lean back and feel the tibia translate forward. A Lachman test is testing the ACL also. It's a bit harder to elicit. The key again is to try to get the patient relaxed. With big knees and small hands, it's a very difficult test to do well, but it is more specific than the anterior draw test. Nowadays, any significant knee injury or any persistent knee problems, then we're going for an MRI scan really very, very early in the patient pathway, and this will be through NHS or private sector. And the MRI scan will confirm the diagnosis. So that's the T1, T2 weighted images is the more useful one. You can see that the ACL here has lost its tension. There's lots of white fluid, so signal change, and the MRI scan shows that there's fluid in the notch here, which is where the ACL is meant to be attached. Early management of ACLs is conservative, so we do not see an ACL injury and and book and proceed with surgery immediately. The patient has to rehabilitate. It's because if we go in too early to operate, there's quite a high incidence of getting a complication of the knee becoming really stiff afterwards. And so actually the early management is rehabilitation. Now, of course, in this last few months, early management has really been non-existent. So we'll just have to see what's happened to this patient cohort. They've not been able to access physio, a lot of them. But the priorities initially is about managing the swelling, regaining the motion, and getting the muscles to function. And at the end of that, when that's been achieved, we can determine whether the patient is going to require surgery or continue with a conservative pathway. This is a very famous paper. So Frobel, and I can't believe it's already 10 years old, he's a great advocate of managing ACL injuries conservatively. And he really stirred things up in the knee community by stating that basically patients can be managed conservatively, and there was really no downside to this. Those that had to have an operation down the line, they can have their operation down the line. However, this paper has been, the response to this paper was a barrage of orthopaedic papers to follow to highlight that although not every patient needs to have a surgical management of their anterior cruciate ligament, certainly delaying the procedure does have consequences. And the consequences are that the ACL is so important at stabilizing and maintaining the knee in the correct place. When the knee subluxes or gives way, then the worry is that the further damage will occur. And there's many papers that have been published subsequently, but what we've found is that if elective surgery is delayed, then the longer it's delayed, the more likely we're going to have associated injuries to the knee. And principally, we're talking about meniscal injuries. So surgery that's performed at 6 months or surgery is delayed at 6 to 12 months has a double instance of medial meniscal issues, and beyond the year mark that increases substantially. So the general message is that if we're going to make the decision to operate, it's better that surgery is done sooner rather than later. However, sooner does not mean immediately, and the first management strategy is rehabilitation. If the patient remains symptomatic with ongoing instability, and that can be quite subtle, the patient is the best judge of this, and a patient that describes their knee as feeling unsteady rather than having to experience episodes of the knee truly giving way, I think is good enough for us to be considering surgery, and that should be done in a timely manner. And we'll just have to see what we're going to discover in the forthcoming months of the barrier to healthcare is going to mean to a lot of these patients. ACL surgery is straightforward, it's routine surgery, and it works well. It works well at improving the patient's stability. It's certainly the best way to get to restore high performance recovery, and so achieving high level of sports is very difficult without surgery. But even for an average daily living activities, those that are struggling to do it with through instability, this can be corrected by an ACL reconstruction. In restoring the stability to the joint, we're able to protect the meniscus and reduce the chance of them subsequently developing degenerative changes. I'm aware time is running out, so I'm going to just quickly touch on arthritis and talk just very briefly about knee replacements, because this is the patient group that has been, I guess, highlighted mostly as the ones that should be able to wait. The roles of the aims of our knee replacement is to improve function. It is a good operation, but is often not considered to be as good as, for example, hip replacements. I think that's certainly true.
No, that's great. Okay, what can I do about that? Okay, that's great. So here we are 3 weeks after left total knee replacement, right knee replaced 1 year ago. Okay, fantastic. That's great. And so was that one leg.
So that's it. This lady's done extremely well. That's at 3 weeks after her surgery. And then a patient sent me this video just to demonstrate how well some of these can function. Sorry, I've choice of music very special. I think so we'll stop the video. Let's stop that there. So it is possible to have a highly functional knee after a knee replacement, but patient selection is just so vital. Knee replacement is an excellent operation at restoring anatomy, restoring alignment, and improving pain symptoms. The concern with the timing of it, I think, is to do with patients such as this. So somebody with very advanced arthritis, and they've been struggling and persevering, but they've had a gradual decline in their mobility. And the concern is that if we wait too long and that patient becomes a non-ambulator, or if that patient's general fitness level gradually declined because of their change or inability to be as active. This is general health repercussions, and it also affects the final outcome of their knee replacement. This is, of course, also the group that we have the greatest concern about because of their comorbidities. And this is the real challenge. And it's finding the balance in this patient group, which I think is going to be really difficult in the forthcoming months as we open up, because there is, I think, a pressure for us to be able to deliver these patients an improvement in their pain levels so that they can function better. But this has to be offset against some of the additional risks. Knee replacements in this patient group is very successful. There's not an issue with longevity. The great discussion and debate about knee replacement is why there's a percentage of patients that do less well. And this is not to do with how long a knee lasts. This is very deceptive. This doesn't tell the whole story. It's to do with why 20% of patients are not happy with their knee replacement. Why is only half of the patient cohort very happy with their knee replacement? These same figures when it comes to hip replacements are really different. Hip replacements, we're talking 80 to 90% of patients being very satisfied. And I won't go through the detail of this, but the latest development in knee replacement surgery is to try to address the variation in patients' anatomy and the evolution of the use of customized knee replacements so that we're able to accurately restore anatomy and hopefully reduce some of the problems that patients are complaining of. I'll just whiz through these last few slides, but basically they're demonstrating the variation in anatomy, and the problem with knee replacements being that we don't address that variation. And there's a percentage of patients that, although we feel as surgeons we can do a fairly successful operation for, the component choice is if you like, a small, medium and large option when it comes to their knee replacement. And the reality is that patients' anatomy is much more variable than that. And customizing that, I think particularly in the higher demand in younger patients, is going to be probably the big game changer in knee replacement surgery, with an accurate restoration of anatomy likely to give the patient a much better function. It's still very early days, but to date it seems to be a very satisfying technical procedure, and although the case numbers are small, I think clinically we're going to see that this will represent a significant improvement in our outcomes with knee replacement surgery. So just briefly in summary, COVID has been devastating to healthcare, and orthopaedics has certainly experienced that. I'm hoping that the future is much brighter and the barriers are gradually easing for us so that we can get back to managing patients and will become accessible again for them. The risk in relation to COVID specifically in elective orthopaedic surgery is low, and for the vast majority of patients is very low indeed. Thank you very much.
Thank you, Paul. We've had a few questions come through, so I'll just read them out. So the first one, regarding driving, what do you advise patients who get temporary locking symptoms whilst they wait for investigations and management?
Okay, that's a good question. The basic rule of thumb is you ask a patient to get in the car and do an emergency stop. If they are unable to do that, or if they have reservations about doing that, then they should not be driving. And that goes for, it's not specific for locking knee, but as for really any lower limb symptom.
Thank you, Paul. And we've got another question. Are posterior cruciate ligament injuries similarly managed to ACL, i.e. conservative at first?
So as Homa mentioned, an isolated PCL injury is extremely rare. Okay, there's 100 times more isolated ACL injuries than there are PCL injuries. So a posterior cruciate ligament injury is usually associated with other ligaments being injured. And if multiple ligaments are injured, they tend to do better with surgery. So there is a vogue with trying to downgrade these injuries with initially splinting, and some of the knee braces we have available now are actually really very good. But to answer the question, if we have an isolated PCL injury, I would certainly start with conservative management. But similarly, they can do very well with surgery if they have ongoing symptoms of instability. So ultimately, our goal is to provide the patient with a stable knee. Now, whether they achieve that with physio-led rehabilitation and initial knee bracing, or whether they require surgery, is the pathway that we have to walk them through.
Thank you, Paul. One last question, again to do with timing. So in the locked knee, what is an acceptable amount of time for getting the MRI after being seen initially? If it is a tear, how quick would you like to treat them ideally? So
I just don't think there's any reason for us to wait for an MRI scan in normal circumstances. So an MRI scan used to be this great barrier to treatment. They're now easily accessible. So I would want to get an MRI scan done within a day or two. And similarly, the clock is ticking in these patients really from the moment of their injury. So I like to get in and do the operation within a couple of weeks of it, and within a day or two is even better. The reality is that sometimes we're picking them up later, but we really have the ability to manage these acutely. And if a patient attends accident emergency, then we'll be managing them on the urgent care pathway rather than taking them through the elective treatment pathway. So if necessary, we'll treat them as a fracture.
That's good. Okay. We just had another one come through. Would you kindly say a bit about steroid injections for knee problems?
Yeah, sure. So I use a lot of steroid injections, to be honest with you. So practices are different. So I have an NHS practice and my private practice, and they are really different. So my private practice, probably the most common thing I see is anterior knee pain due to an inflammation around the fat pad. As I mentioned, I've got a very low threshold to get an MRI scan. So basically every patient will end up with an MRI scan so that we're defining that patient's knee issue. The most common finding is Hoffa's fat pad impingement. You see high signal change in the fat pad. Is typically anterolateral, and it works. Treatment that works really, really well is an ultrasound-guided injection of cortisone into that zone. So that's one patient cohort I think do really well with it. It's usually a one-off single injection. The other patient group that I think definitely has a role is in the degenerative knee. And my first-line injection is steroid. Hyaluronic acid has data which is potentially similar to the use of steroids, but my personal experience is that I find steroids to be better.
Oh, sorry, I muted myself there. Thank you. We've got another question. Any good online resources for GP learning online? This doctor currently uses ortho bullets.
Yeah. So I think orthobullets is fantastic. I don't know of really much better than that. Homa, any thoughts on that? I think orthobullets is succinct and accessible. It's pretty good.
Perfect. Homa, did you have anything? Sorry, before I go on to the next question.
I thrust Homa into that, but basically because I was flagging, I couldn't think of anything other than orthobullets. So excuse me.
No, I was agreeing. Orthobullets is, out of all the websites there are, it's really succinct and clear. So yeah. I like it too.
Oh, thank you.
Yeah. But I guess another message is we're really open to have direct communication with our GP colleagues. I think this is something that is really not utilised, and that be nothing to give myself, and I'm sure Homa, more pleasure than physiotherapists or GPs feeling free to just reach out and contact us directly. I'm very happy to discuss informally over the phone regarding any patient. So I think that's how really medicine is best practiced.
Amazing. And if anybody does want to contact, you can use me as a support. So please do not hesitate to get in touch. Last question, Paul. Patients who have had ACL reconstruction, should they be reviewed after a few years, or do you just leave the patient to go on with their lives?
So we don't routinely follow them. I follow all of my ACL reconstructive patients up for the first year, and I encourage them to come back if they become symptomatic. So an asymptomatic patient, no, we're not following them up. I guess there will be a cohort in that we may consider following up, and that will be the ones that will have associated injuries. So there are some that have significant meniscal loss, cartilage damage already, and we know that we're likely to be requiring further input on their care. But the reality is it's difficult to follow patients up on a routine basis, and I'm very much in favour of empowering patients to come back so that resources are better used.